Hi, thank you so much for being with us. This is very exciting. Um, and we have so many questions about pregnancy and birth and some particulars, but can you start us off with the difference between a midwife and an OB?
Great. So as I speak about this, I want people to understand I am not speaking from a place or bad or good. What I'm talking about is the difference in education, the difference of what's been taught about what we center around. And it's just information because my wish for everybody who's listening is that you have clarity about what feels safe for you when you give birth. So, in midwifery care, the way I was trained as a licensed midwife who specializes in low risk out of hospital birth is I was trained to center around the pregnant person. And it's a relationship that happens. So at every prenatal, I'm spending somewhere between an hour to a half hour asking questions to get to know the person. So we're talking about nutrition. We're talking about exercise. We're talking about that mental, the emotional. They're so important these days. Everybody's talking about histories of trauma. We're talking about spiritual, if you want to be letting that in with someone like myself, right? And we're talking about all of these different things, and we're creating a relationship. It's a trusting relationship that we're creating. So, my job is to ask questions and to hold space. And then your job is to answer those questions and let me know what you need to have a safe space held to tell me what's going on for you. Because one of the misnomers is everyone thinks we're mind readers for some reason. And in the seeing and hearing process, it's a relationship of sharing and telling. So we get to know who you are as an individual. And what I like to say is by the time you go into labor, I'd like all the T's crossed, all the I's dotted. And it might not be perfect, but we've got a relationship and a trust and a communication going on. Now, that being said, where does the safety lie? Well, the safety is like it's a boundary. So I kind of look at this like a clock. There's a boundary, and I do risk assessment, and I've got protocols, and I've got procedures. And in the center of that clock is the relationship, is you. And then there's all these little inner workings of the clock that we talked about. We've got nutrition and exercise and mental and emotional and, informed consent, all those different things that make up you as an individual. But the boundaries of the protocols and the procedures are all the same to keep you safe. Now, obstetrical care. Obstetrical care is a different way of looking at birth. Obstetrical care is currently being dictated by insurance. And insurance mindset is what's the problem? How do we fix it? Which is fantastic if you have a broken bone, right? Because if you have a broken bone, we want to put a cast on that broken bone and fix that problem, right? If you're high risk, we want to be able to use the high risk medications, the high risk tools, the high risk surgeries for that person who is high risk, because there is a problem if you're high risk that needs to be fixed. And what's happening with that mentality is you have OBGYNs at the hospital, and the hospitals are high risk places. They're not taught to differentiate between high risk and low risk childbirth. So when somebody walks through the door, they're not talking about nutrition to keep somebody low risk. They're not talking about the mental or the emotional or the traumas. They're not talking about exercise. They don't have training in that. Because when you're a high risk doctor, those are not things that come into play, right? You are an awesome surgeon. You're awesome at epidurals when somebody can't move. And if somebody can't move in labor, they become high risk. It's not a bad or a good. So they're really good at managing birth. And so what do? They center around the protocols and procedures or the problems that need to be fixed. Out of hospital trained midwives who are trained in home birth are experts in low risk childbirth. OBGYNs are expert in high risk childbirth. As a low risk childbirth professional, it is my job to differentiate when someone goes from low risk to high risk so they can be in a high risk facility known as a hospital with an OBGYN. That's one of my jobs. And my other job is to, again, see and hear you as an individual to make recommendations to keep you low risk. OBGYNs don't have that training. It's not a bad or a good. They're amazing surgeons. They're amazing high risk experts, but they're not trained to differentiate between low and high risk childbirth. So they don't have that expertise in how to guide somebody who is unmedicated in low risk childbirth. They're not trained in how the anatomy changes and moves all the time. They're not trained in the physiology. They're not trained in how to hold space or how to see and hear somebody. It's not a bad or a good. It's just very different.
Mhm. Well, then, there's some preconception stuff that I want to talk about with you, but maybe just to kick it off, I'll jump to one of our burning questions from the community is I'm hearing from a lot of people that they would like a home birth, but that they're not sure that it's safe. So I know for me, one of the things that really allowed me to have home birth was to actually dig into the data. And I'm a data person. Yeah.
Okay.
So I think with making that choice, it's got to start with some emotional desire that there's some part of you that's interested in birthing outside of a hospital. Some people just feel really safe in hospitals and they like them. And
Right.
so, if that is your safe space, but, a lot of people actually feel uncomfortable, like myself. I actually feel afraid in hospitals. I don't feel comfortable. And of
Right.
course, would love to be there if there was a true reason, but digging into more of this data, that was what made me feel safe not being in a hospital. So can you really lay out all of that data for us?
So I don't have access to all of the data up to date. What I do know is there's been studies done in the UK. And in the UK, the data there states that, especially if you're a second time pregnant person, they're actually saying if everything went well the first time and you're low risk, it's actually safer to have the baby outside of the hospital. Or not even safer, but they're recommending it to birth outside of the hospital. And how I usually answer this for people is you have to understand there's a difference between being able to move your body, right? And move into different positions and not be on an epidural just lying on your back in one position. And so if you're able to move your body and your care provider has gone through all the list of things and says you are low risk, has done the blood work, has done the tests, is listening to the baby and knows that you are low risk, it can actually, from my perception, I think be safer to birth outside of the hospital than in the hospital. And the thing is that you're working with a low risk expert. That's different than working with a high risk expert who doesn't know anything about the body when it is unmedicated and it can move. And so understanding the difference between that, I think, can start the educational process of understanding the difference between where you feel safe.
Yeah. Okay, that is helpful. So I guess just going to preconception, and you don't really reach people preconception, but you're going to reach a lot of people today preconception. Um, how do you like to prep the body? Supplements, food?
All of that. So one thing we have to consider when looking at the research, and specifically for the research of women over the age of 35, is the question you want to ask is, when was the study done? Right? Because we have the obstetrical community saying over the age of 35 is considered geriatric in pregnancy. So if you look at the data, it's like, oh, the studies were done in the 90s and the aughts, right? Also, it is 2023, especially your community. We know about eating well. We know the benefits of exercise. We know the benefits of supplements. We know the benefits of nourishing the body. When you look at some of the studies that talk about over the age of, say, 35, those studies don't talk about what people are eating. They don't talk about the supplements. They don't talk about their mental, emotional well-being. So you're just getting this like one-sided study. So this brings me into conception. And the reason why I'm talking about people over the age of 35 is because if you are taking care of your body, if you are eating right, if you are getting good supplements, you're getting good support, you're knowing your body individually, you can conceive past health, have a healthy pregnancy past the age of 35, past the age of 40, at the age of 45. That's all a possibility. And I think with any body, it's really important to start from a place of a healthy liver and a healthy digestive system and healthy hormones. And in 2023, we know that comes from good nutrition, it comes from really good supplements, it comes from getting good sleep, it comes from getting sunlight. You know, there are all these wonderful ways to nourish your body. And what I like to say is that a conscious conception is not just meditating, it's not just yoga, it's all of it. It's the physical, it's the mental, it's the emotional. Prepping in all of those ways is so important, I think, for creating a new life and preparing yourself to be a parent. I mean, you know what it's like. Once you have a child, you've got a personality and they're just gonna bring it all to the surface.
Yeah, it'll be the last time you can care for yourself,
Right?
in a particular way. Um, I want to back up and have you double click because this was our maybe number one. We had a million questions around tearing that we'll get to next. But we had a million questions around having a baby at 40 and after
Okay,
40. That's our community here.
great.
And so you just said a lot about it, but I wonder if you want to say anything more.
Yeah. I want to say that the studies that were done in an era where we as individuals didn't even know about nutrition and exercise and the benefits of it, right? I mean, Amanda, help me out here, but like in the 90s and the aughts, did you know the benefits of like certain herbs and minerals and food?
No, and I think that this plays into something that we talk a lot about, epigenetics, and that age is biological, not chronological. And I know that so many of us really believe that and feel that when it comes to the aging process and what it means to be 40 and a woman now and how we take care of ourselves. And so I see a lot of confidence around that. In the
Exactly.
rest of the world, but there's still this hesitation and this hang up in around birthing and pregnancy. And I think some of it comes from being labeled as geriatric at 35, but there's still this hang up. And
Mhm.
so that's where I really want you to um, help us out, to spell it. Tell
Yeah,
us what you see in pregnancy and birth after 40. Give us some
right.
stories to
So
neurology.
yeah, I mean and I'm allowed to talk about this, but the oldest person in my practice was 47 years old, and she practiced what she preached as a nutritionist, and she had a beautiful home birth and conceived naturally for herself, and it had a lot to do with nutrition and exercise in her body. And I just, I keep going back to that because the biggest challenge is the people who are making up the word geriatric, which is in itself just so insulting. I don't even like using the word. I'm only using it because that's what they're using at the moment.
I'm gonna dispel it. We're going to knock it down today.
Fabulous. But it's the people who are running those tests and coming up with that information. They're not asked, they're not, the people who are running the tests don't have any education about nutrition and exercise in their obstetrical practice. So you're getting this one-sided view of data that comes from the what's the problem, how do we fix it, as opposed to, okay, who are you as an individual? What's going on for you? You know, when you're looking at a person now, you're not just saying, here, take this supplement. Like this is going to fix your problem. We don't even do that anymore when we're doing like looking at the individual. It's like, okay, what's going on in the delicate balance of the hormones for you? What is it that you're eating, whether it's blood type, whether it's history, whether it's DNA, whether it's genetics? You know, what is that balance that works for your body to keep you healthy? And like you said, Amanda, we know the chronological age and the biological age are two different things. But if you're going to expect your OBGYN to understand that, you will be disappointed. In the same way that if you expect every midwife to understand that, you could also be disappointed. So one of the ways of working with this is that you can kind of be like, okay, I'm going to have this care provider, they're in charge of this part. And then I'm going to go to someone who's a complementary medicine provider, or, you know, I've done all the research and I know what supplements work for me. Like you can kind of start compartmentalizing it out so that you can be seen and heard in the way you want to for your individual body, and then maybe see somebody else for more of the broad strokes, right? But it is 2023, and I've got plenty of healthy people who come in over the age of 40, you know, and you know what I like to say is, you know, when those studies were done, like back in the 90s or the aughts, do we know what these people were having for breakfast? How do we know they weren't having like Twinkies and Diet Coke for breakfast? And then they were saying over the age of 35 is not a good idea.
They were definitely breakfast.
Right? Or a tab. Like we don't know what they were putting in their bodies. And what you put in your body will help create a healthy system of a healthy heart, healthy blood vessels, a healthy uterus, healthy skin. Like we know that now in 2023, but Western medicine hasn't caught up with it because they're not looking at birth in that holistic way. Again, not a bad or a good, it's just a different way of viewing it.
Totally. What are your thoughts on egg freezing?
What are my thoughts on egg freezing? Well, I think that it's an individual choice. Um, and I know I've now learned that the data is saying that the frozen eggs don't last as long as they thought they would be lasting. Have you heard about that also?
I have not, you know, I haven't done a lot of research around it. I know it's a thing that a lot of people are doing, especially as careers are changing. And so I think much like the question around, can I birth safely after 40? There's also this question looming around egg freezing.
Mm-hmm. Um, I personally don't think there's enough data to let us know what the long-term outcomes are for a frozen egg that then gets, say, thawed. I get this question a lot. This is my same mentality around ultrasounds. You know, we we understand that, say, doing 2 to 3 ultrasounds for a reason is a good idea, but we don't know what the long-term effects when these children are turning 40 if you're getting ultrasounds, say, every week, or you're going to the mall to get the 40 ultrasounds. Like we don't know what the long-term effects of that. So bringing it back to egg freezing, you know, we have early data I don't know what's going to happen when all these kids turn 40. If there's something going on that makes it a different, I don't know, DNA or something different in the biology. So part of how I think is you always have to look at the risks and look at the benefits, and you got to weigh it out for yourself personally. Also, how I think is that data is always changing, research is always changing, and you need to look at, are there long-term studies on what you're talking about? Are there 40-year studies on what you're talking about, or is this new information? And so for some people, they're like, I'm all good. Whatever happens in 40, 50 years, I don't have a problem with. And there's other people who are going to be like, there's no information on that. So that might not be a good choice for me because I'm not comfortable with that.
Yeah, informed, just getting informed every step of the way.
It's getting informed every step of the way, and also getting to know who you are. You're making parenting choices. Who are you as an individual? Who are you as a parent? You know, when I have someone who's coming to birth with me, there is a difference between the mom who's like, yeah, you know, I was raised on an ashram in Oregon and like all laid back. I watched all my siblings being born, or the mom who comes to me who's just like, so my father was an ER doctor, and he's like every day at dinner, he would tell me the horror stories. So, like, here are like my really structured boundaries. So, how someone was raised is also going to inform who they are.
Yeah. You're reminding me of dear Dr. Crane. Anytime I've ever seen him, he's like, I don't know, you're fine. You're very relaxed. You realize, oh yes, he might, there might be some very uptight birthing people that he sees.
Mm-hmm.
You know, there's just, I get it. There's a lot of fear around birth, which is why I love having this conversation with you. Because the more you learn, I think the more comfortable.
Right. And here's the trick. The trick is to have clarity for yourself, right? I talk about this with my sister. I share this story. So my sister is an amazing birther. She is great at birthing her own children. And she is one of those people who could easily birth at home. So she had two children, and then she watches the business of being born back 15 years ago. And I just become a midwife. I wanted her to watch it. And she came out of there and she said, Lizzie, I know two things. One, I'm having a third child. And two, it is being born at a hospital.
Oh,
Right?
wow.
Yeah. She was like very clear. And it's like, you've got that clarity. That's where the health is.
Yeah.
That's healthy. She knew what worked for her. Great. Now, what I would never do is take someone who's had two great first births and said to me, you know, I'm really clear. I want to birth at a hospital. I would never try to convince that person to birth at home because all of their fears are going to start coming up of why they don't feel safe at home. And then there's this weird thing that happens. It's like, oh, they're going to prove themselves right, like a self-fulfilling prophecy,
Mhm.
right?
Yeah. And, you know, on that separate note, but related, um, what are some ways you help your clients? And this can start before you're pregnant, ideally start before you're pregnant. Anybody who's had trauma,
Mm-hmm.
previous birth, um, and then anybody who has sexual trauma or
Right.
has had sexual assault. I mean, I know that comes up in birth too. So, what would you say to somebody who's not pregnant but has had these experiences? How can they, for themselves, but also for a future birth?
Mm-hmm. Yeah, this is a great question, and this is actually one of my areas that I like to talk about because I have a background in somatic training from Ray Castellino and Anna Chitty. So, first of all, what I want to say is when I speak about this, if my tone is very matter of fact, um, please don't misinterpret it. And please know that if you have a history of trauma and sexual assault, I'm so sorry you had to go through with it, and it is not okay. So that's the first thing. So the cells of the body work somatically. Okay. Somatically means see, hear, smell, touch, taste. It works on the senses. Okay. It's not a thinking part of the body. It is more of that autonomic part of the body, more of that primal brain place. So when one gives birth, sometimes if you're not differentiated, and I'm going to explain that in a minute, the cells of the vagina might feel something coming through and not know the difference between a violation that the little one is saying no to and not being heard, and a baby moving through the body that you're saying no to and you want it to stop, but it's not going to stop because the babies keep coming out into the world that way. So what I'm trying to say is if the cells in the vagina are undifferentiated, or you don't understand the difference between your present age self, your adult self that has chosen to have this baby, has chosen this care provider, has chosen the people in the room, so it's a choice, and knows it's a baby, and doesn't know the difference between that and the violation that happened back then with the younger self. If you aren't able to differentiate between the two, your whole body and the cells in your body are going to go, no, no. And it can literally stop the baby from coming. Okay. And then you're in a place of the baby wanting to come, knowing to come, trying to come, but the body saying no. Okay. What's going on is the younger age self that had the violation is kind of in charge. And the work that needs to be done through therapy or somatic work is to differentiate and to know, okay, back then that happened. It wasn't okay. It wasn't fair. All of that. And let's say if it's a 13-year-old self, I'm just picking a random number. It's like, okay, so back then when I was 13, I was trying to say no. I wasn't listened to. I got that. And right now I am 35. I am in charge. I have chosen this baby. I have chosen these people. I have chosen this situation, and I am birthing my family. So that's called differentiation. You're differentiating out your adult self from your younger age self. Okay.
And what kind of therapies do you see being really effective? Is it EMDR? Like what kind of somatic work?
Yeah. I love EMDR. I love havening. And then, I've been trained with Ray Castellino and Anna Chitty. That's some of the work that I do. Or you can go to those websites to find people who know how to do that. And what you're really looking to do, you don't even have to have like months and months of therapy. If you go to someone who understands trauma and understands EMDR or brain spotting, you can go in and say, listen, this is my history. I am wanting to birth my baby vaginally. I want to get really clear that my adult self is in charge and really help that place. And you can go in and just do a couple sessions around that piece, and then you can get tools. So can I share just a couple quick tools that are helpful? Yeah.
Please.
Yeah. So one of the things that we can do to help the person become their present age self, which is their current adult self, doesn't matter what age they are, 23, 35, 45, but your present age adult self, which is where the health is. Your present age adult self is listening to this recording. Your present age adult self knows how to research. It is clear about who the care provider is and has asked for things and, has researched, right? So you can tell your mind, my present age self knows all of this. Is then how do we get you into your present age self? Because birth can be very primal. And if it goes primal, also the eyes get closed. It can be very much an internal experience of, right? And if you're in that place with your eyes closed, you might not know if you're 13 or 35. So one of the things that somebody there can do is say, open your eyes, look at me, open your eyes. Now, what is your name? So what's your name?
Amanda.
Right.
All right, I
And
just I went really deep in
right,
birth
so,
case.
right. So it's like, so open your eyes and look at me. What is your name?
Amanda.
Right. How old are you?
I shan't be telling you.
35. Just say you're 35 because we're working with
35.
35, right. So your name is Amanda and you're 35 years old. And you're like, that's right. My name is Amanda. I'm 35. Okay. Now, what color is the painting background?
Aqua.
Right. What color is my couch?
No.
Right. What color is the wall over there?
White.
Right. So here's what I'm doing. I am having you go to the right side, to the left side. Okay. That helps with the brain. You're moving the eyes from the right and the left. Okay. Helps with the wiring of the brain. That's number one. Number two is I'm just having you name colors. We all know colors, right? Naming the color is kind of occupying the brain, kind of distracting it. And all of a sudden, you can become more present. All of a sudden, it's like, oh, that's right. Okay. And then my name is Amanda. I'm 35, right? That's my adult self. Oh, that's right. And oh, I chose this. Yeah. I chose this. And you get back online and you get into your present age self, and your adult self becomes in charge, and your little one isn't running the show. That is a simple way to differentiate.
Um, do you have any resources that people can, if this is resonating with them, they can go, they can do the work, they can have their partner do the work, or invite a doula
Right.
to do this work with them?
So I know how I do it. I have a class called History, Hats, and Hormones that is online, that they can always purchase and watch. For myself, they can always hire me for private coaching consultations, and I can work with people one-on-one. I believe in relationship care. I believe in witnesses. I believe in being seen and heard. So there's a lot of work that you can do by yourself, but having somebody who can help witness it, there's something about that that I think really ingrains into the nervous system that becomes really helpful. I think going to Psychology Today is one of my favorite resources to find somebody who does like EMDR havening or brain spotting. And that's a really simple thing to do. What I'm talking about with the differentiation, I don't know of other birth workers or midwives who do that. I think that's something that I've developed over the years.
Yeah, I don't know of anybody doing that either, which I think wherever someone is and having their birth team is to bring that piece, which probably will be very helpful for doulas and midwives.
Right. So you're inspiring me to start teaching this, but you have to remember, Amanda, I've been doing this for my God, since we met, like 15 years-ish now. And so back in the day, everyone's like, oh, Elizabeth, that woo-woo stuff. And now we know it as brain science.
Totally.
Right?
Can you can you tell us more about havening?
Oh, yeah. I got trained in havening. Have you done it yet?
No.
Okay. Havening, they say, is EMDR on steroids.
Mm.
So it's the same thing. You're working with the delta waves in the body. A simple technique for havening, which can help regulate the nervous system, is actually slowly or fast. You're touching your hands. I can feel my whole system settling. You can just simply do this, and it brings you into the delta wave patterns. I like to go slow. Some people like to go fast. There's also doing an E on the face. You can do it to yourself or have other people do it to you. This can bring somebody into the delta waves, slow everything down, or starting at the shoulders, coming down through the elbows into the hands and reversing it. You know, these are simple techniques that you can use during labor also. But the havening itself is working with the delta waves, okay? And what you're doing is working with you're working with an individual who's been trained in this, and they're bringing up the trigger and then bringing in both distraction techniques and the delta waves in order to help rewire it and reprogram it in the brain so you're not as triggered.
Yeah. And so
It,
it's like EMDR, but you've
yes.
been instructed to do this for yourself.
Yep, you're going to be doing it for yourself. And then there's also other techniques and other guidance of like songs you sing or counting or things like that to help in the rewiring process.
Okay. This is incredible stuff to be able to bring into birth.
Yeah.
And I like the point that you made that, it doesn't have to take forever. This is something you can be very pregnant and hearing this, realizing that there might be that little thing that's going to come up for you in birth, and you can start tomorrow.
Right? Exactly. And listen, piggybacking on that also, the community that I think we're both part of can sometimes put too much pressure on the pregnant person to have a conscious birth look a certain way. You know, it's got to look like you're meditating and you're listening to mantras and you're breathing your baby out, or you haven't done it right. And I want to say that when we say there is a right way and a wrong way to do it, we're not having a conscious birth.
Mm.
When we put the judgment on it, we are stepping out of being fully present and fully conscious, and we're going into that black and white either or mentality, which isn't the point. I think that being conscious is about being present, and it's being present with whatever happens. But it's not just saying, I'm good with everything. That tends to be more disassociation.
Mhm.
I like the idea of research, we talked about planning, crossing the T's, dotting the I's, being with a care provider where you feel seen and heard, and stating, like knowing yourself. This is what makes me feel safe, and this is what I need. And if that person can't provide for what you need, move on to somebody else. It's all okay. Right. But being present with that. So whatever comes up, whatever shows up, we can hold space for, not saying you're going to like it,
Mhm.
right? Not saying it's going to have to be easy or look a certain way, but being able to hold space for what shows up. What might show up? You might be the person who every time you get a contraction, you're like, I hate this, right? And you might just want to be seen and heard in the hating of it. And then I'm looking at you going, yeah, you hate this and you're doing it.
Mhm.
You both hate it and you're doing it.
Yeah, it's an interesting point. I think there's so much birth media out there, which on one hand is really lovely. I mean, I follow like 15 different birthing accounts, and
Mhm.
as I'm scrolling through every day, I get to witness these incredible birthing moments, and I can share that with my daughter. But you're right, the woman is very placid, it's silent.
Huh?
There's maybe some breathing, maybe a little, but
Right?
not much more than that. And I am a primal screamer. And that is actually it's been so helpful in my births. It's like when the baby's coming, I know it. And there's a sound
Uh-huh.
that would, I'm sure, be the same sound of me being stabbed to death. Um, and that's been positive for me.
Right. And so within that, because we're gonna thread in that place of people being scared of out of hospital birth. Within that, If you're making that sound and it's not comfortable for you, or your partner's hearing that sound and it's not comfortable for you, there is a difference between uncomfortable and not safe. Right? So your partner might be hearing you go, ah, I hate this, right? And then your partner is going to be like freaking out because it's like, wait a minute, I thought she was supposed to or like whatever it is. And then it's like you go to your care provider at your out of hospital birth and you're like, is this okay? And we go, yeah, this is part of it. Let me listen to the baby and let you hear the baby. So you can get some accurate reflection. We use Dopplers outside of the hospital. They work in the water, they work in the shower, the tub, on land, all of that, and listen to baby. And then we can give you that accurate reflection of going, baby's safe, mom is safe, and the sounds are uncomfortable. I get it. I totally get it. And she's so strong. She's got this. She's doing it. So we're making space for all of those things to be present. And then this is what I call accurate reflection, especially if you're brand new to this, right? You get the reflection from the care provider that you trust of like, baby's safe, you're safe. And yeah, you don't like it and you're doing it.
Yeah. Another huge question we have is VBAC.
Yep.
Can you tell us your thoughts on VBAC?
All right. So the first thing that I think is really important for anybody to know who's having a VBAC is that the evidence does state that you want 18 months in between the births to make sure that the scar tissue of where the surgery was is really well developed, so we don't have any fear of that. Right. And then you want to take a look at the physical things. You want to make sure the placenta is not on that scar tissue, right? Because we don't want the placenta to get embedded into the scar tissue. That could be a problem, right? So you want to take a look at some of the physical things that could happen because of the initial surgery to make sure on a very physical level, you're still safe and considered low risk, right? Then you want to figure out, well, why did you have the C-section to begin with? Were you trying for an unmedicated birth and you had a care provider who doesn't know about unmedicated births and didn't know what to do with you wanting to get in whatever position you wanted to on the bed, and then you didn't feel seen and heard, and then you got nervous, and then the labor stopped, and then you got scared, and now you're in a C-section because you didn't feel seen and heard and you didn't have the right kind of care provider who understood what you wanted. Is that a reason why it happened? Great. So find another care provider so that you can settle and open. You probably have a really good chance of a C-section, right? Did you have it because there was a breech birth and you're in a state that doesn't allow for breech birth vaginally, which is a whole other discussion, right? And so, great, let's try and see if you can have a VBAC, right? A vaginal birth after cesarean. We have to figure out what the reason is. And then it's like, how can we support that to be a different choice? Okay. So that is, you're looking at the physical and then you're looking at the reason why. Okay. And then when you understand the reason why, you need to be able to show up within yourself also. Is the reason why because you weren't on top of your nutrition and you ended up gaining like 70 pounds, which impacted your ability to move, and and you ended up in a C-section for that, and that's the reason why? Great. So you're going to work with a nutritionist this time. You're willing to show up to make the changes on nutrition. Right? So you're finding out where you need to show up and how it's physically safe. And then the important thing is you got to be with a care provider who feels safe around it. If you're with a care provider and they say, oh, I don't like doing VBACs, you're not going to have a successful VBAC, right? It's just not going to work.
Yes.
And then one of the things that nobody talks about, except for I think a lot of the out of hospital birthing community talks about, is talking about the mobility in the hips. Okay. Our hips are made to move. The sacrum moves, the hips move, all of that moves. We currently live in a society where everyone's driving everywhere, right? If we're driving everywhere, pressing the gas, we're pressing the brakes, we're pressing the gas, we're pressing the brakes. What do you think is going to happen on a physical level to like the muscles and the ligaments all in that hip joint? It's going to get shorter and tighter.
Mhm.
Right? So if we have a hip joint that's short and tight, say on the right side, we have a hip that can't open up. And how do you have a baby opening up? The opening is supposed to be like this. And say it's shorter and tighter, the opening is like this, and all of a sudden the baby can't fit.
Mhm.
This is straight up anatomy. So if you've had a C-section, one of the first things I'll always say to you after everything else is, I want you to go see a chiropractor. I want you to start stretching. I want to make sure that your hips are nice and open for a baby to really navigate that
Mhm.
the most fluid way possible. I think the best chance of having a successful VBAC is making sure the hips are open and stretched with stretching and even chiropractic care.
Mhm.
And I don't think people talk about that. The other thing that people don't talk about is we also live in a society where there's a lot of over exercisers because we think, a little bit of exercise is healthy, so we're going to do even more. And we're not having the conversation about all these wonderful people who are doing yoga, but they're doing mula bundas all the time. They're doing the in and ups all the time, and they have a super, super, super strong core that doesn't allow for flexibility. We're not talking about the people who are doing this Pilates all the time with that super, super, super tight core, or the gymnastics or pole dancing. We're not talking about how those people who are really into the exercising and from a place of really being tight need to loosen up and need to relax to not have the C-section. And
Yeah.
that's where you get individualized care.
And are you seeing, we had some questions around back labor
Mhm.
and women that have had previous births with the back labor and they're really afraid. How do you prevent it going forward? And my first child was back labor, unmedicated back labor. And so I really hear that. And that was my number one fear
Right,
around having my second child. And I didn't have it, just to put that story out there for
right.
people. One of the things that I heard in the aftermath as I really dug into where could this come from was Pilates and was yoga. And so is that consideration for people with back labor? Are there any other things?
Yeah, hold on. Do you know what? Give me a second. I want to get my doll and pelvis.
Oh, okay, yay.
Yeah, so give me a second to get them. So let me go back to, here's the pelvis. So we have the opening of the pelvis, the inlet dynamic. We've got the outlet dynamic. If you're driving a car all the time, right? Starting, stopping, starting, stopping, starting, stopping. You go into labor like this.
Mm,
Do you get how the baby's going to try and fit? Because the baby wants to come into the world. And the baby, right? A baby's going to go, well, how do I fit into a pelvis that's a little awkward? Well, maybe I'll come in from the side, which is called asynclitic, or maybe I'll come in sunny side up,
mm,
right? Because I'm trying to fit. It's a relationship we got going on, right? So the other thing is what you were talking about is that with the Pilates, with the Mulabundas, we don't have the flexibility that we are wanting kind of in the abdomen here. Like I want some flexibility because the baby, when it comes down, it rotates to come down and fit. It's supposed to move. And so if you're doing all the mulabundas, right? and you're doing all the Pilates and the baby's coming in and can't move and rotate because there's no flexibility in that abdomen or the perineal floor, it's kind of going to do its best to come, but it might decide it fits better in the inlet dynamic sunny side up. And then it can't turn to navigate the rest of it. Now, let me show you another. This is another fun fact. Okay, we got the baby, right? So here is the baby's head. What part is the small part and what part is the big part, right? When the chin tucks to the chest, we have the smallest part of the head presenting. That's the ideal way of fitting. And that typically happens when we have a baby that is OA. It's not back labor. It's not OP. It's OA. It can tuck the chin to the chest. Right? Now, what happens if your baby decides to suck the thumb and wear an arm as a scarf? Right? It's harder to tuck that chin to the chest. So you got the bigger part of the head presenting. So it's going to try to fit. And as it does that, it's like, well, maybe I'm going to go sunny side up. Maybe I'm going to go OP, and, it's going to be back labor, but that's the best way to present if I've got the bigger part of the head presenting. This is not the stuff that's taught in midwifery school. This is not the stuff that's taught in obstetrical school. This is just observation of kind of figuring this out. And so my question always is, okay, so what is the body saying? You're having a labor that's starting and stopping, prodromal labor. You're complaining of back labor in between. There's no problem to be fixed. It's information. So what is your body saying? What is your baby saying? It's saying, I'm trying to fit, but I need some more support. What could that support look like? It could look like something called the rebozo, which is a traditional Mexican technique of kind of shimmying the belly to get those hands out of the mouth to get the baby to go away, to get the chin to tuck to the chest so we can fit through the pelvis. Okay, so we're looking at a couple of things. You're looking at, we want a pelvis that can move different ways. Okay, for that flexibility so the baby can come down. And then we also have a baby that's trying to fit and trying to move and is giving information to us about what support it needs. So when you gave birth the first time around, I'm going to say, I didn't even know this to be true, right? It took time to figure this out and to understand, what is that baby saying? What is the body saying? And so now when I have someone presenting with signs of the back labor or a labor that's starting and stopping called prodromal labor, the first thing that I do as a midwife is go, I wonder what's going on with that position. I wonder if there's hands in the mouths, and like, what could I do to support that? It is not a magic bullet, but I think it can work a lot of the times.
Yeah, smart. So I want to talk about due dates, and due dates, particularly in California. And so maybe you can walk us through just the legal situation there, how midwives are bound to adhere to certain things, why you think this 42 weeks is there, what would happen past 42 weeks. I think just having an understanding there. And then I'll just preface by saying, if I were to ever have a third baby, and I wish I had done this with my second, I know that I just gestate for 42 weeks. It's who I am as a person. I would, to take the pressure off of my birth team and myself in that last week, because most midwives get very nervous at 41 weeks. And as the days clock on, that you're going to wind up in the hospital with Pitocin. So I think my totally illegal hack, and I'm just going to throw it out there, the midwife is not saying it, I am saying it, is I think that I would lie about my conception date. And you can tell me this is a terrible idea. And I think that I might give myself an extra 10 to 14 days, just to take the pressure off?
Mhm. Um, I'm trying to think how I can answer this question because I do have a medical board license.
Yeah, you don't have to answer that part.
So yeah,
My
so
rogue, that's my rogue thought, and then you can
yeah,
just.
so what we are trying to do, just going back to the beginning conversation, is we are trying to keep people safe by centering around protocols, by centering around a problem that needs to be fixed. We are not centering around individual one-on-one care. So you have to remember that all of these studies that talk about when it is safe and unsafe to birth a baby outside of a hospital or just birth in general have to do with care where you're not seeing and hearing the individual, where you don't know their history, you don't know their gestation history, you don't know any of that. Right. So, Amanda, you're telling me you have a history of gestating babies at 42 weeks, and it's a version of normal in your family. And I've worked with families like that before. Right. And I've worked with them before the law changed. So, the law currently states in California it is illegal to birth a baby before 37 weeks or after 42 weeks outside of the hospital. Okay. These rules have come about based on studies. I'm saying it again, where the individual is not seen and heard, and there's no relationship with the care provider, right? They're just looking at the physical. And when you look at the physical, those studies say the chances of a fetal demise will double, right? After kind of that, I think it's the 41 week time at this point. But when we say it doubles, it goes from like, I don't know, like a 0.0 something, and it doubles in that way. But people are always hearing, double. Okay. So that's the law. That's the way that it is looked at. Again, when you're centering around protocols. Now, let's look at the other side of that. You're working with a midwife who sees and hears you as an individual. Okay. And this was before all of the laws happened and changed. I have birthed babies at 35 and a half weeks that were 7 pounds. You know, they're healthy, they're able to be in the world. We had an OBGYN who said, yep, it's fine for you to go into labor. The body went to labor on its own. It didn't go into labor because there was an infection. It didn't go into labor because there was a problem. They didn't go into labor because there was something called cholestate. Like there wasn't a reason other than that's when the baby went into labor. And then the body went into labor, and then the baby's coming out early. And so what do I do? And it's like, well, early babies sometimes can't hold their temperature. So guess what we're going to do? We're going to put in extra protocols. I'm going to come to the house. I'm going to call you more often to make sure the temperature is okay with that baby. And I'm going to work in relationship with your pediatrician to make sure it's okay. Right? I'm not just saying, sure, birth that baby at 36 weeks at home and don't worry about it. You'll be fine. Right? I'm seeing and hearing the individual, the history, and I'm working in relationship with the pediatrician and with you to make sure that baby continues to be safe outside of the hospital. Now, a baby born early that way is very different than we're going to induce your baby at 36 weeks or 35 weeks for medical reasons, for the OBGYN going on vacation because your partner travels all the time and that's when they're in town. So the studies have let us know you don't want to induce before 37 weeks, which has also gotten translated into any baby born before 37 weeks is high risk, so you can't birth them outside of the hospital. All right. So that's one thing. Then the other end is past the 42 weeks. I have, before this law came into place, I was helping people birth babies at 42 and a half weeks, 43 weeks, because that's just how their body did it. And they were not having ginormous 10-pound babies. They're having 7.5-pound babies who are still covered in vernix that look like they're early, right? Because that's just what their body does. Now, within that, I'm also being an adult. I'm also conscious of what the studies say, and we do something called informed choice. So once you get past 41 weeks, we do informed choice. Here is the data that the CDC says. Here is what the obstetrical care says, right? Here's the studies. So if you want to go past that 41-week mark, which you can with an out of hospital birth, it's still legal up to 42 weeks. We have to have the data on the other side to say you and baby are safe. So what does that look like? You go in for more non-stress tests, which is when they we listen to the baby's heart rate on a monitor that tracks it and contractions, and it let us know the baby is healthy through the heart rate. What else does that look like? You're looking at the fluid levels through an ultrasound. Great, fluid levels look really healthy. They're not so low. Your placenta seems to be working really well, right? So you're getting the data of listening to the baby and the heart rate. You're getting the data of the fluid levels. And so if we have the data that says it's okay, the chances of you becoming a statistic get reduced, right? Because you're being an adult and you've got that information, right? Because the studies aren't saying, this person who was 41 and a half weeks had an ultrasound and a non-stress test that showed this, and so they were higher risk of a poor outcome. They're just lumping it into anyone over 42 weeks, you got to be induced because then you're going to have like a dead baby. Right. And I'm not, and the other thing is it's done in relationship. It is informed consent. It's like, okay, Amanda, I want to let you know we practice evidence-based care. This is what the evidence says when they center around the protocols, the problems, and the risk assessments. But I'm looking at you as an individual. Here is your history. Here is what the ultrasound says. Here is what the non-stress test says. Here's what the studies say. Here is all the information. Are you willing to meet me in this and be informed and take on some responsibility?
Yeah.
Right? Yeah. That's a relationship where you're seen and heard.
Yeah. And with that, and so for your, and we have many questions around induction, ranging from hospital inductions to natural things people can do at home to more natural things people can do with a midwife, and a lot of questions around membrane sweeping.
Oh yeah. Let's just start about membrane sweeping. Let me explain what that is. It's when your care provider goes up inside to do a vaginal exam and they're feeling the cervix. The cervix is at least 1 centimeter dilated, so we can get our finger inside the cervix. We then take our gloved finger and you're sweeping the inside of the cervix to release prostaglandins by separating it from the amniotic sac. It is not breaking the water. I want to be very clear about that. It is an aggressive vaginal exam. Your care provider should give you the choice about whether they're doing it or not. And what I have a huge problem with is people come to me and they say, that was the worst vaginal exam ever. They pulled on my cervix. Like it was like they were in there for a while, like for 30 seconds. It was so uncomfortable. And now I'm like kind of getting cramps. And it's like they just swept your membranes, but they didn't give you informed choice on your body. It's so awful, that part. So it should always be an informed choice. That's number one. Number two is that if sweeping of the membranes worked all the time, honestly, there wouldn't be other things. There wouldn't be Pitocin and all of that stuff. I believe that sweeping of the membranes can be part of a natural induction, and you kind of want to layer it. First of all, if I'm going to do it, it's because there is a medical reason for it. I don't believe in sweeping of the membranes at 40 weeks to get somebody in labor just because they're done being pregnant. right? It's kind of like, okay, you're 41 and a half weeks and your cervix is nice and soft. And we've got that boundary of 42, and I want to help your nervous system be relaxed. So, what's the plan for you and who you are as an individual? I like the idea of sweeping the membranes, getting some acupuncture, taking some herbs, doing some nipple stimulation, and doing all of that for a couple days together. And you're kind of layering it to get the best effect of going into labor. Sweeping of the membranes will always give you some contractions. So I always look at it like, when you're on like a motorboat and you're like, "Rrr, rrr," like you're trying to get it started. It's like that sweeping of the membranes can get it started, and then you want to build on top of it. Where I have seen sweeping of the membranes be very successful is typically in someone who's already had a baby, and it's kind of like their second or their third or their fourth ish, and they're having contractions that are starting and stopping and starting and stopping and starting and stopping, and then we do a good sweep of the membranes, and that can really get somebody into labor from that place.
Mm. And so I did sweeping of the membranes with my second child actually in your birthing center.
You did.
I did. And I had this great plan. And forget Michelle. What's
Yeah.
her name?
Yeah. Michelle Reyes. Uh-huh.
Who sometimes works in your spot. So Davy was off and I was going to go, I think it was 41 and a half weeks. I was doing the whole recipe. There was
Uh-huh.
sex, there was walking, there was acupuncture, there were herbs. And so I was going to try this. And then we were going to go to a restaurant because we were just doing the eating tour of LA. And we were going to have this nice lunch date after the sweeping of the membranes. And I got the membranes swept, and I was really shocked by a pretty wild reaction I had to it.
Mm-hmm.
I was like very emotional feeling. I felt scared. I felt I felt really weird. And so I stuffed it down for the little walk to the restaurant. And then we got to the restaurant and I started hysterically crying and, did not feel right and went home and needed to be in my little cave. Um, and I read somewhere after that that sometimes there's some hormonal release that can happen that can make you, can you talk to us about that? Because that was a surprising thing. And I feel like people should be prepared.
So the hormonal release, I I think the hormonal release can come a lot of different ways. I actually get excited about hormonal releases.
Mhm.
So it can come from sweeping of the membranes because you're going to get a surge of that prostaglandins, and it's going to start with the cascade of hormones in the body. And so even just feeling that in itself can bring stuff up. I sometimes like to recommend that somebody like go watch a good movie where you're going to cry, right? And like at this point in time, both OBGYNs and midwives, like you're fully pregnant, it's like, half a glass of red wine is going to be okay, like to relax. So it's like, have a half a glass of red wine, watch a movie where you're going to cry emotionally. And sometimes that release of the emotional tears can actually get someone into labor also,
Mhm.
you
Yeah,
know?
don't go to like a new hot restaurant in Silver Lake to cry your eyes out in public.
Oh, but what you were listening to also is okay. So you've got the hormone surge in your body, which is what the sweeping of the membrane is supposed to do. And you experience not just on the physical level, but you experienced it on the emotional level. Like what happens for us when we get our periods? Like we have the hormone surge and changes in our body for the physical level, but it also affects us emotionally also, right? Labor, labor, you got to have the hormones start to surge and change to bring you into labor. And what can happen? You can start crying. Oh my God, I'm going to be meeting my baby soon. I'm just so happy. Or like you're crying because you're so scared. Postpartum, the hormones start to surge, and all of a sudden, like, because they have to surge to bring in the breast milk, and all of a sudden you're like, I am so in love, and why is the sock on the floor? And I'm never gonna get out of this chair for the next 17 years, right? All at the same time. It's part of the hormonal surge. We just feel everything.
Yeah. Um, And what role does semen play any role in induction?
Yeah, they see semen contains the prostaglandins that are needed to actually soften the cervix. Because there's a couple of things with the cervix you want to happen. You want it to open up and you want it to thin out or soften. So you need both of those things to happen. So the semen contains the prostaglandins needed to soften the cervix so that once your body starts to contract, it can open up. And once your body starts to contract, it brings baby's head down onto the cervix to get it to open up. It's both of those things happening. So we love that. Plus, orgasm, whether it's through penetration, whether it's by yourself or with a toy. If your water is broken, please no penetration of any kind, whether it is a toy or whether it is a penis, no penetration once the water's broken. Very clear about that. But an orgasm gets the uterus to contract. You get the uterus to contract, right? You might start going into labor. Why not?
And so it's the orgasm that we like, it's the semen on the
Uh-huh.
cervix
On
that
the
we like.
cervix.
Is there anything about the mechanical act of sex, like opening your hips, the penis in there that does anything, or it's really the orgasm and the semen?
It's really the orgasm and the semen from what I have been taught. I am not sure how opening of the hips works with a baby inside down on the hips. Like, did you experience like the hips opening up more?
I know that, and this is like way too much TMI, but yeah, I won't do that much TMI. Okay,
Okay.
I will say that right before birth, maybe hours before birth, there was like somehow really nice missionary sex. I don't even, I'm like in
Huh?
my mind, how are we even doing that? But there was like splaying of the legs that felt good.
Right.
It felt like, oh, this is like opening stuff. And it
Okay.
was,
So
yeah, it was
I'm
sex.
gonna go into this just to explain what I'm hearing you say. So missionary is going to have the legs coming out. Oh
Mm,
no, missionary, hold on a second. It's going to help. Like the legs are going to go out more and it's going to open up that inlet dynamic. So on a physical level, you know what? We may have just discovered something new, right? Every time you move your legs into a different position, you're on all fours, right? You're standing up. You've got one leg open. Like all these different positions are opening up the inlet dynamic in different ways, the outlet dynamic in different ways. So in labor, there's a lot of similarity to sex
mhm.
on a physical level and on an emotional level. All right. And this is where I share too much about my sex life, which I'm happy to do. But personally speaking, if I am going to enjoy myself in sex, I like to know the name of the person at the other end of my vagina, right? I like to know that I'm going to be listened to, right? I don't like it cold. I like to be warm. Personal thing. I think a lot of people like to be warm. I also don't like bright lights.
Mhm.
Okay. I need really good lighting, soft lighting, dim lighting. I'm an auditory person. So, what I'm listening to music wise really affects me, affects my rhythm, affects my breathing, all of that. Right. And when I've got kind of all of those things happening, I just drop into that primal brain where I am feeling the dance. I'm not thinking, well, what does the book say to have an orgasm?
Right.
Right? I'm feeling the dance. And within that, my body is moving in a way that feels safe, that allows for things to happen for an orgasm, right? What do we know about childbirth outside of the hospital? Okay. We know that we want to get some oxytocin going. Oxytocin's a love drug. When you're having an orgasm, you've got tons of oxytocin. You fall in love with the person at the other end of the vagina or yourself. It's everywhere. You've felt that before. Everyone's kind of felt it for the most part. So in labor, oxytocin is needed to create the contractions in the body. It's been scientifically proven trust creates oxytocin. Oxytocin creates trust, right? So who are you? Not even you, Amanda, but just the people listening. Who are you as an individual? Are you as a sexual being? Are you the person who's like, yeah, I'm fine with tons of people watching and bright lights, I'm performative, not a problem for me? You might be the person who does really well at a hospital and you're like, I don't care. I'll just do whatever my insurance says. I'll be in the hospital with the bright lights or home. Like, it doesn't matter. I'm good. I feel safe everywhere. Or are you the person who's like, well, I really have to have just like the least amount of people in the room, some good music. It needs to be warm. It needs to be dark. And then I surrender. And then I drop into that primal brain where I don't know whether it's been like 2 minutes or 2 hours. And my body is leading me towards where I need to go. And I'm dropping into the rhythm.
Yeah.
So that place can also get somebody into labor. So when we talk about an orgasm of having the uterus kind of contract, we're also talking about the oxytocin being released, feeling safe, feeling seen, having that kind of love drug, that trust drug going through the body, which creates contractions.
Yeah.
So that's how, like, we can use the physical and that spiritual and that safety, mental, emotional, to get somebody into labor.
Yeah, that was one of the thoughts I had God, like almost 13 years ago with my first birth. And it was not the sexy thought, but my thought was around when I'm sick, I really like to be alone. Not that birth is like being sick, but I thought particularly around throwing up. And I just thought when I throw up, I like to be alone. I like
Oh,
to do my own thing. I got this, just leave me alone.
right.
And some people really like to, when they throw up, like hold my hair, be with me, bring a washcloth. And that was one of my thoughts around birth.
Right. And so I have a question for you. With the birth of your daughter, was it the same thought?
No, the birth of my daughter was like, this is going to be amazing. I had no fear around it, and it was going to be amazing. And I didn't really want anyone there but my husband, just because it really felt like a holy event between my husband and I and our child. And so I was not, and we have some questions around free birth. So maybe we'll segue into some free birth, but I felt like what was going to help me relax and feel safe was to have somebody around that I could completely get into the body and the primal self and know that that person would be there. And if anything seemed like it'd be wrong, they'd get me to Dr. Crane, or Dr.
Right.
Crane would come, or I'd get to the ER.
Right.
So for me, free birthing was, I really wanted that backup person to check. But I didn't really want that person around.
Right.
And I
Yeah.
didn't want a doula. Uh, yeah.
So what I'm hearing from you is you, the person who birthed your son, changed and grew and evolved, right? And, different things happened in your life. So by the time you birthed your daughter, you were in a different place.
Yeah.
So it doesn't mean the person who birthed your son was right or wrong. You were different. And in that space, what was true for you was, I'm going to be alone by myself in the toilet. Don't touch me. And your life changed and you changed and relationships changed. And then when your daughter came, it was like, yeah, like kiss me, touch me, but just my husband, care provider over there. Like, you know what I'm saying? There's
Yeah.
nothing wrong with either one of those. It's about accepting where we are and what our truth is and not judging it.
Yeah. And I think knowing yourself, that
Right.
was kind of the point of bringing it up is if you're not relating to, well, what do I want in sex? Because I think most people don't want people watching when they're having sex.
Right.
But maybe like yeah, how are you when you throw up?
Right. Yeah. And part of reason why I talk about that with the sex part is you have to understand hospitals don't hospitals are high risk places that aren't interested or they're not taught. Like say, not I'm not going to say they're not interested because they don't even know it's part of birth, that the hormones in the body are what help somebody get into labor. They don't understand that a dark room, a warm room, unobserved, where there's room even for kissing or cuddling and trust could help somebody get into labor. That's not part of them because they're like, there's a problem. You're not in labor. We're going to fix it with inducing you with Pitocin, or we're going to induce you with Cytotec,
Mhm.
right? They're not looking at the whole person and seeing and hearing you, right? And everybody is different with their needs around trust and their needs around safety and whatever that is. Mhm.
Um, so we had some questions around epidurals, and then detoxing from an epidural. And so what effect, and again, I think it's a full spectrum and nobody's saying that getting an epidural is bad,
Yeah.
but in the spirit of informed consent, we obviously know the pros of an epidural is it will alleviate pain. What are some of the cons of an epidural? What does somebody need to think about for themselves and their baby?
Well, they need to think about where it is going. Like the fact that when you get an epidural, you're having a needle put into the epidural space that puts a tube in to feed the medicine and the needle comes out. But some people, because we're all individuals, will have reoccurring pain in that area, right? On a mental level and a physical level, some people will get an epidural and it just doesn't take. So mentally, they're like, oh my God, soon I'm not going to feel anything anymore. Soon I'm going to have relief. And then the epidural comes in and they've got like pain still in one side and not the other. Or it doesn't last that long because of how their metabolism is. And mentally, that's just a really hard one to watch. You can find studies that say the epidural doesn't affect a baby, and you can find studies that say the epidural medicine does affect the baby. I think you can find studies to support both ways. Um, those are kind of like the physical things in the epidural. The other things you want to look at is the fact that people don't realize once you get an epidural and you can't move, you're also having a catheter, a urinary catheter with the epidural, right? Because you're not going to know when you need to pee. And if you're having a straight epidural, a full epidural, not a walking epidural, you're not going to be able to get up and go to the bathroom. So you get a catheter. People don't realize that they have to have IV fluids the whole time. By the way, for everybody listening, you don't need IV fluids running in your body 24/7 if you're having an unmedicated birth. Like you're low risk. Why do I need to give you IV fluids? And if you're outside of a hospital and you need IV fluids, I can give them to you for nausea. I can give them to you because you want antibiotics, because you might be GBS positive. So always choice around that. So that can always happen. But they go in and out. It's not a continuous IV fluids. Continuous IV fluids are really important and need to happen if you are planning to get an epidural or have an epidural. So you've got like one arm that's got like the continuous IV fluids in it. Then the other arm is hooked up to a blood pressure cuff. So you got this going off and on, off and on. I don't know, every 15 minutes at first. And then after that, longer stretches of intervals. So you've got an epidural, a tube in your back, not the needle, and you're numb. You can't move, which you want so you don't feel the pain. You've got the urinary catheter because you can't feel when you need to pee. You've got this arm that's got the IV fluids. You've got this arm that's got the blood pressure cuff. And so you need to know you've got other things happening. And for some people, if they've got, a serious history of some kind of violation or trauma, that could be something they don't want to do. It could be really hard. Right. And I have zero issues with an epidural. What I have issue with is the idea that we think birth is a problem that needs to be fixed with an epidural. The pain of childbirth needs to be fixed with an epidural. I have a problem with that way of thinking. Right. So what I do with everybody I work with and everybody at GraceFull is everybody has a code word. Code word is something you wouldn't say in a zillion years. And this is something everybody can adopt and you agree with it with your partner. Right. So it's like, say, it's food that you hate or that you're allergic to, or a store you would never go in, or you're professing your love for somebody you don't like. It's got to be something that would never come out of your mouth regularly that you have to think and use, right? So if you're in labor and you're that person who just wants to walk around going, I hate this and I want an epidural, but you're using that languaging because all you're saying is, please tell me it's going to be over soon. Please tell me I'm doing a good job. Tell me to get into another position. Help me get in the water to relieve this pain. Like, see and hear me in this, right? You can say all the words that you want and even scream for an epidural. And then we look at you and go, you have a code word. And then what happens 9 times out of 10 is the person turns to me. She's like, I'm not using my code word, and that's just how the person's birthing. But if you use your code word, that means you're not in pain, you're suffering. And on the inside, you need an epidural to have a safe, present birth. So, you know what? Choose that epidural and choose it from a place of empowerment. You know what the risks are, you know what the benefits are, you know what's going on in your body. Say your code word out loud and go, I'm serious. Great, let's get you that epidural. And that's an empowered epidural. That's very different than just routine because that's what you've been told.
I love that. Thank
Right?
you. And what are some other, so in hospital birthing, and we had a lot of questions around this, what are some ways that people can advocate for themselves? And that, and that could be like a 7 hour chat, but
Yeah.
a little checklist for you.
So I'm just going to do what I know, which is honestly why, I've written the book and the workbook around it.
Right.
And it's literally, it's like, it's all about the questions, like questions to ask yourself. And then back here, it's like all these questions to ask your care provider, right? Because the problem is that we don't know what questions to ask to find our own clarity because we're not even told what all the choices are. Right. So there's a difference. You could say to your care provider, like, what position am I allowed, what position can I labor in? And if you're working with an OBGYN who's hospital trained on high risk, they might be assuming you're going to have an epidural. And if you have an epidural, you can't move. And if you can't move, the position that you're in is lying on your back, typically at most hospitals. So they're going to say to you, you're going to be lying on your back. Right. But there's a difference also be saying, I really want to have an unmedicated birth. This is, what can I labor in? And then there's a difference between labor and pushing. Right. So you might be saying, I just want to labor in whatever position I'm in. And they're like, the doctor's like, great, but by the time you're pushing, I want you lying on the back. Or you might be the doctor who goes, whatever position you want to push the baby in is fine by me. I was trained by midwives. You can be on all fours. You can be on the side of the bed, as long as baby sounds good and I can listen to baby and get a strip, I'm fine with it. But you won't know unless you ask the person. So you're finding out what is their training. You're having a list of all these questions that you can research yourself to figure out where you are in it, right? An episiotomy, which is a cut at the opening of the vagina towards the anus, and it's through the perineal tissue. I love my episiotomy scissors. They're an amazing intervention if I have to get a baby out in an emergency to make sure I have a healthy baby, I'm not going to hesitate to use them. Now, do I want to use them? No. But there's a difference between a care provider that's like, yeah, I use episiotomy scissors routinely, and someone who says, I don't use them routinely, but if there's an emergency, I will use them for how they're created. But we're living in a society right now that's like, episiotomy scissors bad. And it's like, no, 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 no. They're great if they're not being used routinely. So you got to know what question to ask so that you can understand the philosophy of your care provider.
I'm just having a friend moment, and I just like my respect for you as a friend, because we don't
Oh,
like sit around and talk about your episiotomy scissors. But I just love that my friend has episiotomy scissors and she's not afraid to use them.
right? Now, I don't want to use them. And if I use them, I'm going to be having conversations in my head. Did I really have to? Does it, like, I'm going through all of that myself, but oh
You're
yeah, I'll be
confidently
using them
using
if I
them
need
to
them.
save a life.
What?
You're confidently using them to save a life.
Exactly. That's why they were created.
Okay. On that note, we want to know what happens to the clitoris during birth.
The clitoris stays where it is. Doesn't move out of the way. I mean, listen, okay, everything is stretching. So fun fact, the cells in the vagina, right, and that make up the labia and all of that are the same cells of the penis, right? What does the penis do? It grows bigger and it goes back to its regular size. What does the vagina do? It gets bigger and goes back to its regular size. Okay. Um, with the clitoris itself, it's going to stretch and go out of the way. So it's going to go to the top part of the head coming out, right? It's not going to be like the head's not going to like get it. God, I wish I had a clitoris right now, like a doll clitoris. I have a clitoris. So a doll clitoris. So it's like, it's not going to just like be in the way. It's going to stretch and it's going to get out of the way. All right. Everybody, when you're birthing outside of the hospital specifically, nobody wants you to tear. Right? We pride ourselves if there's no tearing going on. Somehow we think we did it, but we really didn't. It's you and your body that doesn't tear. And one of the ways you can prevent tearing is by going slow. And I'll talk about some other stuff as the baby stretches everything. It's meant to stretch, right? In the stretching process, depending on your skin integrity and or your birthing position and or who the care provider is and their understanding of it, there are some situations where a tear, it starts to tear, to separate, and sometimes it can happen up by where the clitoris is.
Mm.
You got lots of nerve endings there. And please, if you're the person who tears up towards that clitoris, right? Because we know that the clitoris isn't just the nub, it goes all the way down with nerve endings into the labia. So if you tear around there, please know the nerve endings are going to grow back. Might take some time, but I promise you're not broken. But it could tear up there. And so here's what I like to do. I like to hold a space and I like to have conversation with the moms beforehand. And it's like, I would love it if you felt a burning sensation somewhere in the perineum, by the clitoris, by the labia, by the bottom of the perineum, wherever it is. I would love it if you could put your own hands wherever it's kind of burning and do some counter pressure. Now, I've been taught to do counter pressure, and I can, and I typically do it on the bottom of the perineum, or if I see it starts to get really red or stretching, and I have the person go slow. But if you're starting to feel it tear or burn, do the counter pressure. Typically, that's up by the clitoral area and the labia. Do counter pressure on your own body to help prevent a tear.
Yeah. We had a lot of questions around tearing. The number one question was around birthing after 40. The number two question was around tearing.
Okay, so I'm going to say something, and I'm going to preface this by saying the FDA does not approve this device. But I am not recommending it medically to anybody. So be very clear, but I'm going to let you know there's a device in Europe and it's called the EpiNo, EPI-NO. It can only be bought in Europe with a European credit card and a European address. It stands for episiotomy no. I think it was created in Germany. And it is do you know about this device?
I do not, but
Okay.
I'm loving this.
Right. It's like a latex device that you put air into and you're like blowing it up. It's like a ball you blow up. So what you do is you insert it into the vagina and you look at the pressure gauge and you blow it up with air until it gets to a certain number. And then you do kind of, I love it because it's like a biofeedback and you start to relax. You start to use your breathing techniques to relax all around it.
So you're using this when you're pregnant before birth.
Starting at 35 weeks. Exactly. So the EpiNo is a device that you insert into the vagina and you put pressure into it to get it to blow up to a certain size. So you're putting it in at a certain pressure number, and you're going to be learning that biofeedback of relaxing around it to let it come out. And at the same time, it's putting pressure on the perineum to start getting it to stretch. Okay. So every time you insert it, you're going up to the same pressure number, but the idea is it fills with more air. So it gets to hopefully the size that's about 10 centimeters.
You know what? So I did not do so I did not know about the EpiNo, but I think that's exactly what I was looking for. With my second birth, I think second times moms, second time moms have a little bit of fear. I feel like especially unmedicated, you know what it feels like. And for me, it was like the fantasy of the painless birth. That bubble had burst, and I realized that birth for me is painful, and that's okay.
It's just you can do it.
But it's painful, but you can do it. And so I had Kimberly Johnson.
Uh-huh.
I don't think this is a service she offers, but I asked Kimberly Johnson if she could come over at the end of my pregnancy and if she could. So Kimberly Johnson, how would we describe her, Elizabeth? Is she a sexologist? She works with trauma in the body. It can be sexual trauma. It can be birth trauma. She works physically on you.
Right. She's an expert on the perineum and all of the muscles and the tissue and all of that there and what it may or may not be holding.
Yeah. So I worked with her before I was pregnant with my second child. And this is someone I would recommend, whether you find Kimberly, she's in Brooklyn now. I know she also comes back to California. She's great and someone you can work with. So I worked with her to release some of the trauma that I felt like I was holding on to from my first birth. And that did wonders. It really, like, I emotionally let go of a lot, just as you were saying, Elizabeth, that there's memory in the vagina, that the cells hold on to things. And so really by having her get me to bring up some of the feelings that I didn't even know I had around my first birth. And it was an interesting experience. She puts her hands inside of you and she said, walk me through your birth. And we got to a certain part and she said, well, tell me how angry you are. And I said, I'm not angry. I'm not. And I had never related to it in that way. And she said, she really coached me to get in touch with a more primal emotion that was there, and it came out. And at that moment, she pressed on some of the perineal muscles, and there was a release. And I walked out of there just having like 200 pounds lifted off of my shoulders that had been there for years, that I knew that there was something, but I didn't know what it was. So that was an incredible experience. I asked her to come back years later to my house before I went into labor and do this like EpiNo thing, I guess, which was, can you take me to the place of how big a baby's head is? And she did, and I was not in labor, and I could feel it, and
Mhm.
it was really fine.
Yep. So I've done something with people, I just called vaginal reflection or pelvic reflection, and just putting my hands in. And when they're not in labor, and it's like, okay, I'm going to put my hands in. Now I'm going to push down, of course, all with the permission, but I'm going to push down because I want you to feel what it feels like to have like a head coming through. Right. And
Mhm.
so I'm pushing down on the vaginal floor. And if we push down on the vaginal floor, like a head coming through, Amanda, what do you think your body's going to feel like it needs to do?
Well, I mean, in labor, you feel like you really need to poop. You need to
Right.
push poop.
Right. Because what's happening is the head is pushing down on the vaginal floor and it's pushing down on the rectum, bringing them close together. And so those nerve endings are getting all excited as though there's something in there that you need to poop. And it feels like you need to poop. Right. Which is amazing because what happens when you poop? You don't sit there and go, okay, now I'm going to take a deep breath in and now I'm going to push. It's an automatic response of, right? And so
Mhm.
your body's going to lead you through that. Now, what the mind can do in labor, because of how we have been socialized and raised, not a bad or a good, is it goes, oh my God, I got to poop. I'm going to poop. I'm going to poop everywhere. I'm going to poop in front of the person I love and this doctor and this nurse and like, I don't want to poop. Right. See what my body's doing? It's because it doesn't want to poop in front of everybody. Right. How does a baby come out the vagina if you're doing this? I don't want to poop. Right? And it's not even poop that's coming out. So here's the deal. Your body is so wise. Before you go into labor all on its own, you're going to like your body's going to empty itself out. And so like if anything is going to come out, it's like squeezing a tube of toothpaste and there's little nuggets that come out that we just like move out of the way. I get excited when I see those little nuggets because I'm like, yes, you're pushing in the right place. Right. But on a mental level, it makes sense that you would go, nope, scary, don't like it, don't want to poop, right? So the biofeedback part comes like, with what you did beforehand is getting like also a felt sense of that before. And you're like, oh, that's how it feels. That's what the body does. Great. The epi, no, it's going to fill up the whole space and the nerve endings are going to get excited and you're going to feel a felt sense of what it feels like. And then this is the part I love about it. You are going to feel a difference between a natural reaction of there's something in my vagina, I don't like it, which is normal, right? That's human. And then it's the difference between, and that hurts, and it actually makes it hurt even more between, okay, I got breathing techniques. That's the baby's head. And then all of a sudden you soften with the techniques you learned. You've softened with the trust. You make more space. And the weirdest thing is it doesn't hurt as much when you soften around it and the pushing versus, that like, I don't want to, like, this hurts. So I want to make it stop.
Yeah.
Right? Did you have that experience also at some point of noticing the
Um,
difference? Because everybody, I think, at some point goes through a like, what is that? And then it hurts more. And then it takes time while you're pushing to learn to relax and soften and push.
So I didn't really have to push. Everything happened so quickly that actually with both my babies, certainly with my second one, it is like a train moving through the station.
Mm.
I'm not pushing. I'm like hanging on to the side of a birthing pool because the train is moving through the station. And so I did a little bit of panting, but it really like she just came out.
Right.
And it's fast. And so that's where my primal scream comes, but it's more like I just let go and hang on.
Right. So you might have experienced what's called the ejection reflex. Have we talked about this?
No, but it sounds like it. Tell us about this ejection.
So the ejection reflex, some people have this, which is they describe it as the train moving through the station. You can't stop the train. And typically it kind of comes out of nowhere. And for some people, it's like the midwife can check you and be like, oh, okay, great, you're 6 centimeters. We got about 2 hours, 3 hours. And then all of a sudden it's like half an hour later. It's like, wait a minute, are you put like how'd you go from like 6 to 10? And it's like the baby's in the arms and like it's not even a push. It's like the body is ejecting the baby pushing.
think that's exactly what happened. One of my requests for the birth was, I don't want any talking, but you can give me some words of encouragement when it feels right. And you know, I felt very connected to my midwife and trust that when the words wanted to move through her, it would be right. And so we didn't talk about much. And I said, and please don't check me unless you feel like it's necessary, but don't give me a reporting if you do
Right.
do it. So she had checked me, and in hindsight, I found out that I was 6. She didn't report that to me. I felt like I was about to have a baby, and I heard her whisper to Greg, "Do you think you could make me some black tea?" And I just remember that was like the one time I came out of my primal eyes closed, like it's all happening. That was the one time I was like, this bitch thinks that, and
Right.
Davey,
We love her. She's
in a
amazing.
way, but my birthing brain was like, this bitch wants black tea. She's gonna take my husband away to make her black tea because she thinks she's staying up all night. I'm about to have a baby. And I just thought, nobody knows I'm about to have a baby. And it was a few contractions later, I ran to that tub and
Yeah.
the train came through the station.
Get the ejection. That's called the ejection reflex. Mm-hmm. Mm-hmm. And it can be a lot for some people.
It was a lot. It was a lot. You know what I remember was, and this is an interesting thing because you have this thing of, I just want the birth to be fast. And you just pray for like, I just want it to be as fast as possible. And I remember all my midwife friends, you included, had said to me for years, yeah, but you don't want it to be too fast because
Right.
that's not. And so, yeah, a fast birth is intense. I just remember it was really fast with my second one. But with my first birth, the baby comes out, and I was like, oh my God, I made eye contact with him.
Uh-huh.
And it was a spiritual experience. With the second one, with it being so fast, I couldn't regulate my breathing and I wasn't aware. And it was so shocking for the body that it was maybe like 45 minutes after the birth, my midwife saying, okay, now the breathing, let's bring it back. And I was not aware. But it was not, I was not in that like relaxed, lovey-dovey, like my baby at first. It was, I think for
Yeah.
about an hour, I was in shock.
Yeah, I actually see that a lot when you've got the ejection reflex. There is a lot of shock, and it's a little like your body's over here. Let's like bring you back down. But what's happening is makes sense. Like your body's like, that's too fast. We're out of here, right? Like can't handle what this is. It's too much. I'm too overwhelmed, right? That makes sense. The body would do that. But what brings the health in is naming it, talking about it, connecting to it, allowing you to have your feelings around it. If it's too fast for someone and they didn't like it, it doesn't mean you don't love your baby, right?
Yeah.
The health becomes we can have more than one complex a big emotion at the same time. Like
Mhm.
you can be like, that was too fast. I'm overwhelmed. I can't find my body. I'm scared. And I still love my child. But right now, I got to like figure this out.
Mhm.
Doesn't make you a bad mom. It's just you got a lot going on.
Yeah. I mean, it was fast and I liked it.
Oh, nice.
I was kind of out of my body and had to like find the re-regulating of the breath and sink in. But I was grateful. I was grateful for that. Like, whoa, it just happened. There wasn't tearing. We're all here.
Yeah. Happened at home safely. Didn't need to call Paul Crane.
Yeah, yeah. Um, so we had some other questions around, and I'll whittle it down to like our last few questions here.
Okay.
So, GBS, is there a way, if you become GBS positive, is there a way to naturally reverse that? And then the other part of the question is, if you are GBS positive, what are the implications of refusing antibiotics? And
Right.
is it worth doing that?
Okay. So as a medically board licensed midwife, I practice evidence-based care. And the evidence-based care states that once you have been diagnosed as GBS positive, you are always GBS positive, and it is advised that you get antibiotics in labor. Okay, that's the whole, what's the problem, GBS? How do we fix it? We're not seeing and hearing you as an individual.
And
Okay.
GPS, just for people tuning
Right.
in.
Yeah,
Again,
it's group beta strep. It's a bacteria that we all have. Like I have it right now. Your male partners, your female partners will have it. It's just a matter, is it in the rectum or is it in the vagina? It's cyclical. If it's in the vagina at the time of giving birth, and your water is broken for an extended period of time, and what they don't talk about is there a weak immune system? Is there a strong immune system? This is what I talk about. And your baby gets exposed to the GBS. It's not just bad, it can be fatal. Okay. Now, you've got that way of looking at it. What's the problem, GBS? How do we fix it? Antibiotics. Now, you've got individualized care where you're being seen and heard. We're giving you evidence-based care. We're letting you know what the CDC advises, which is the antibiotics. And then, like, who are you? What's your history? You can do a Google search and you will find there is lots of herbal suggestions of how to kind of have that GBS go away or to get a lower count. And I'm not going to say what those are. Everyone can Google search. And you can ask to be retested. Now, legally speaking, again, once you test positive for GBS, you are assumed positive the whole time. Common sense hat. If you are GBS positive at 35 weeks and you get retested at, say, 38 weeks and you are GBS negative and you have your baby at 39 weeks, which means it's cyclical to go away, what are the chances of your baby getting GBS? Right? Of coming in contact with that. That's seeing and hearing as an individual. So what we do is we do something called informed consents. We give you all the information and then you understand, as a medically licensed professional, it is my job to recommend what the CDC says. You as an individual have been informed of my job and what the CDC says. And then it looks like you've got some extra information to make a decision around. And you might choose to decline the GBS. You might choose to have your urine checked for GBS to see if it's systemic in the whole body or it's just contained in the vagina, right? If your water breaks before labor begins and you're 37 weeks and you have a high colonization of GBS, it might have broken because of the GBS. And you might be like, I really want to get those antibiotics. I think that's a really good idea. Or you might be 41 and a half weeks, GBS positive. The water doesn't break until about 10 minutes before the baby's born. And you might choose not to get the antibiotics. Right? Again, this is not medical advice coming from me. I am just giving scenarios and situations and information.
thank you for that.
Welcome.
Okay, last topic is seeding after a C-section. How can people talk to their care providers about doing this? And you'll tell us what seeding is.
Yeah, so seeding is the idea that we're going to take some of the vaginal fluids that contain all kinds of bacteria. The word bacteria does not mean bad bacteria. We got good bacteria, we got bad bacteria. It's 2023. We all know about gut colonization, prebiotics, postbiotics, probiotics, right? So bacteria is in the vagina, and as the baby comes out through the vagina, it's getting colonized with that good bacteria, right? So the idea is that when you have a surgical birth, the baby's not going through the vaginal canal. So when the baby comes out, we take a sterile 4x4 and you ask your care provider to put some of that fluid in the vagina onto there so you can rub it onto the baby. So if you want to ask for this, and I'm not saying it's a bad or good, just be prepared for them to not get you. Be prepared for them to eye roll. Be prepared for them to go, that's not evidence-based care. Be prepared for a personal opinion and not a medical opinion coming your way. Don't expect them to understand. If you want them to understand, it's probably it's not going to happen with most care providers.
Well,
But
maybe this is a question you bring back to our prior questions for when choosing a provider.
right, exactly. But the other thing you have to remember, it's your body, it is your baby. And guess what? You're going to be raising your child and not me. And I don't know anybody who is just like la-di-da, I'm just gonna put this in my vagina and put it on baby because like I guess I'm supposed to do it. Like the people who are asking for that are people who have researched it. They know the benefit of it. They know why they want to do that and they want to colonize their baby. So, you know, what I tell people to do, if that's important to you, it's not really happening at the C-section. Get yourself a 4x4 in the postpartum room when the baby's hanging out with you. And when nobody's there, just go ahead and do it yourself or have your partner help you do it. And it's your body, it's your baby. Go for it.
Okay, that's helpful. And then babies born in caul.
Oh, I love the babies born in the
I know,
caul.
we all love the babies born in
Okay,
caul.
so
Do
here's
they
what
get,
it means. Wait, go ahead. What was the question?
do they get the seating? So babies born in caul, you can explain it better than I can, but do they also need that seating?
Oh, that's a great question, Amanda. I've never even thought about that.
I know it's always like a spiritual event when it happens, but they're not getting the microbiome, the vaginal
Okay,
biome.
so this is going to bring another question, and maybe we don't need to do the seeding after a C-section because what about the idea that the good bacteria is able to get through the amniotic sac somehow? Has anyone tested the amniotic fluid to see if the healthy bacteria microbiome's in there?
I would assume that that's happening. But then there was all of this evidence and this push towards like, that it really gets shoved up into the sinuses in the mouth when it's coming through the birth canal.
Right. So those babies born in the caul aren't. That's a really interesting point. So for those who don't know, there is the amniotic sac that's all around your baby that keeps your baby in amniotic fluid. Okay. And right now, if you are pregnant, your baby has an amniotic sac around them with the amniotic fluid. And just a fun fact, what color is your baby on the inside? Because they're getting all the oxygen from the umbilical cord. Your baby on the inside is blue because it's not breathing air. It's in fluid getting its oxygen from the umbilical cord. So when your baby comes into the world, what color is your baby going to be? It's going to be blue as it pinks up and starts breathing oxygen. So I know tangent, sorry about that, but I love that fact. Okay. Right. So when a baby is born in the caul, it means it's born with the amniotic sac intact. And so you're going to see the sac coming and the baby's right behind it. And sometimes it breaks like you'll see the sac and then it breaks and the baby's like right behind it. Other times the baby can be born fully into the sac and then we have to break the sac. They say that the babies that are born with the amniotic sac intact are born with the veil between the worlds intact. There's one door in, there's one door out. And so they're born with like these psychic gifts. That's what they say. And then back in the day, back in the late 1800s, when a baby was born in the caul, they would take the caul and they would dry it out. And then they would sell it on the black market to all of the sailors as a form of protection because they're like, oh, it kept the baby safe in water. It'll keep you safe in water. And so I have families, and I've got one from a dear friend, like a little piece of the caul that she put in a charm and gave it to all of us to keep us safe. I love that stuff. It's like medicine, that medicine. But the whole idea of the baby not getting those biomes, the microbiomes, like that's a really good point. I never even thought about that.
Maybe we'll think about it.
Yeah. And one of the things you wanted to touch on was free birthing also.
Yeah. Yeah.
So I have supported plenty of people to free birth. And it's a way of thinking that is not traditional, current traditional, as we have been, as society has conditioned us to think. And this is not a bad or a good. Okay. And it's a way of birthing, and it's a way of being in your body and being connected. This is how I perceive it, to your strength, to your intuition, and listening to it and being present with your baby to birth your baby. Now, in being connected, I sometimes think this piece gets missed by certain people. In being connected and doing that free birth, it's also about listening and going, something's not going on the way I thought it would. And so coming into relationship then with the high risk experts at the hospitals, whether it's for getting into labor or having that C-section or a postpartum issue. And so it's really about coming into your own self and being self accountable and being self responsible. And there's nothing wrong with that if you're informed and educated, and I've supported a few different women who I think we both know, some of them, and like to free birth. And it's like, great, you know your body and you know what's going on. And of those women, two of them reached out to me, and one ended up needing to be induced because she ended up with a fever and ended up in a C-section for the third. It's public knowledge. It's Katie with Empower Birth Project. If anyone was supposed to have a free birth and have it go successful, it was her, because she already had two successful unmedicated vaginal births. Didn't work out that way, but she listened. And it was, there's another person who I was helping. The placenta wasn't coming, so I went to her house to help her with that. And she had a really gnarly hemorrhage we had to stop. So it's like, she had the resources there for the just in case. And so we worked in relationship with that. And I just, recently had a beautiful birth with a client. They really wanted the free birth experience, but wanted to have a midwife there for the just in case. And so I'm like, great, I don't need to do any vaginal exams if I don't need to do them, and I don't need to be part of it, and your husband can catch, and all beautiful. And then the baby comes out, and it was a little like, oh, baby needs a little support of some of the tools that I have. Great, I got the tools.
Yeah. And I think that, again, it's not just a hospital, and for everyone, that free birthing is unattended.
Mm-hmm.
They do that, but
Yeah.
Sorry if somebody didn't know that. But I think that just like you want to really talk to an OB about birthing and how you're allowed to do it, that's a conversation to have with your midwife really early on. Is if you've got preferences around, I don't want to be checked.
Mm-hmm.
I don't want you to talk to me. I
Yeah.
probably don't want you in the same room. I think I'd like to have almost a free birth experience. And, I think there is that middle ground.
Yes.
And I had a great experience with that. It's like, I want to be with my partner, and I
Right.
want the baby. I want to be myself. You
Right.
can have somebody that's pretty hands off.
Right. And part of this also is respecting the OB or the midwife's safety zone, right? Like, I'm fine to do it that way with somebody who is willing to be responsible and show up. I'm not okay doing that for somebody who's going to sneak around or lie to me or not tell me the truth. That's going to put my license at risk, and that doesn't feel safe for me.
Like if somebody was going to tell you that their due date was actually 2 weeks later than it was.
Yeah,
Right? That was my rogue idea earlier.
right.
And
Well, we can talk about some ways to do that safely.
Okay, and then the place I wanted to end was actually some of the work that you've been doing more recently in death and in
Yeah.
helping people with death. And I just wanted to hear from you. What are some similarities between birth and death?
So it is said there is one door in and one door out. And the similarities for me are about holding a neutral space and holding a big enough space for the person to feel safe with whatever is coming up for them, you know? And within that, knowing myself also and knowing the places in me that need to be healed regarding death. I've already done a ton of work regarding birth and my birth process. And so for that one, I'm pretty clear and don't have the same triggers I used to when I first started in 2003. But with death, it's also like, you know, what's my comfort zone around this? And I will tell you this personally, the first person that I helped with the dying process, it was really going against this place in me that was like, oh, I can't let somebody die. Like my job as a birth midwife is part of it is to make sure nobody dies. I got, you know, to save that life. I do have my own personal issues with playing God. That's not my thing, but that's part of my job. And when someone's dying, that's like it's allowed, right? And then it's like you think about it just not as a midwife, but as a humans, where, you know, we're part of this like problem fix it mentality is we're going to avoid death. Like we're going to like fix the problem of death to extend our life as though we're in charge of it. So I had to really navigate this place in myself that's like going, oh, okay, I gotta hold, I'm holding space for somebody to leave. It's like you got to get your head around it in a way. And it becomes the most beautiful gift. And at the same time, there is beauty in there, there's heartache. And I also I want to share from my own personal experience. One of the first people I did this with is a dear, dear, dear friend, and you know, I lived with her for a month to help her. And what I learned after is like, we not only do we not talk about this, but when you're with someone 24/7 on their process of dying and leaving, you're in the grieving process and you're so present with it that when it eventually happens, it can be a little bit of a different experience because it's not a shock per se, and you're just present with yourself and with them every step of the way. It's a different experience than um just getting a phone call that somebody's died or going into a hospital and watch it be managed, you know?
In that moment when, you know, there's like that glow in the room that people talk about when the baby's born, that moment, and then, you know, the moment after someone dies, is there similar energy in the room? Is it like different
I think it
in?
varies. I think it varies. I've had an experience where I know when the person left their body in a spiritual, energetic way, but the physical body stayed on for a good 24 hours. And that was unexpected and that was hard. And like, you know, like so many people are like, I just want to be like, ooh, the baby comes out. I was like, I'm just gonna watch, I'm like gonna wait for that like moment, like the last breath. And of course it, you know, it didn't happen the way because it happens so many different ways. Um, but there is, at least for me, there was a real ability to, and this is what this person wanted also, to honor and respect the physical body. And I knew, you know, and this even touches my tears, there was a physical body there, but the person that I loved and had the relationship wasn't in the body anymore. And that's different than a baby coming into the body because they're coming into that body and that life force is just right there, that untainted, that pure, that innocence. It's right there with you in the moment of birth. If you really can slow down enough to feel it, it's there with every child. And it's like a palpable there. And for me, when I'm helping somebody die, it's a palpable not there.
Mm.
And gratitude for this physical body that served this soul is just, it's very true and real for me.
And and are these all unmedicated death? We haven't been able to catch up properly on your work around this, but I know one of the thoughts that, I feel like I've had my children and felt strongly about having unmedicated births and really being present in certain, I had my list of reasons. And so now my mind is wandering to an unmedicated death. And I have so many questions around that.
Yeah.
Um,
I think it's different for everybody. And with this person I was so close to, we actually were having home hospice. And so there was medication involved as per her doctor at the last moments. There was support given to her to help with a pain. Mm-hmm.
yeah, I mean, I just have so many questions around that.
Graceful dying, my friend Paige is the expert at it, and she guided me through everything, and she guided me through and taught me everything that I know. But she is, it's interesting. Two best friends. One is an expert at helping people in, and the other one's the expert at helping people out. And then we both support people with both birth and death.
And so is graceful dying, it's not a death center. People,
No.
this people who are choosing to be at home.
No, Paige coaches people through it with whatever they choose, and she's got an expertise and background in some of the Tibetan lineage, and working with the oh God, what's it called? It's the Bardos.
Okay, yeah, wow,
And then
amazing.
also has prayers when they're in the body to help them out, through a chakra system, which is what she has trained me in and what I've used. And I'm a big fan of support. And as a midwife, I've learned to ask for support. That's part of my journey towards health, is realizing that if I have good support, then I can really support the families I'm with. And in the dying process, I had a lot of support. I have enough health in my body to say, I can't do this alone. I need support to be present for the person. Right. And that goes back to what I talk about with like relationship. I think there's a lot of health when you can say, I don't know and I need support. Or when you can start figuring out, what does support look like for me? If you're in labor, what does support look like for you? Right.
Yeah.
That is part of the health and part of coming out of that paradigm of there's a problem to be fixed, seeing and heard. It's like, you as the individual, like, let the midwife know, let your doula know, this is what support looks like for me right now. I don't know what's going to happen to mom in labor, but for right now, I can tell you this, and this works for me and this doesn't. And so the midwife can go, you know what? I can help you with that kind of support. Or maybe the midwife's going to go, that's really out of my comfort zone and I can't do that. So you might need to find another midwife.
Mhm.
Right. And it's the same thing in the dying, the death and the dying process. We all have wishes and things we want, and you want to do the consent with it. And then sometimes you get a curveball on the way out and something else happens. Mm-hmm.
Well, more offline about that. But
Uh-huh.
thank you so much for all of your knowledge. And from what I was hearing in our conversation, there is a course that you have that people can get into.
Yeah.
Are you holding up a workbook for somebody who wants to better navigate their process in the hospital and how to advocate for themselves? I
Mhm.
heard you say that you are supporting people that are not just in Los Angeles.
Mhm. I do coaching. A lot of what we talk about is birth planning, but I help people come up with a birth plan. But in the process of doing that, I'm helping you get to know your truth as the parent of this child, and whether you've had a previous birth or a previous trauma that we want to help integrate the system, or you're just curious and you want to know what all your choices are and just need some support to talk to your care provider to be seen and heard.
Yeah.
Mhm.
Thank you. Thank you.
Oh,
And definitely if you want to know more, or any of this was ringing bells for you, even before you're pregnant, or even after you've had a birth and you want to just walk through some things, there's no one else like Elizabeth. So I really encourage reaching out, having a conversation.
you're very kind. And hopefully we can hang out soon.
Yes, we will.
All right.
Thank you so much. We'll text, we'll talk, we'll see each other. Thank you for all of this.
All right.
Okay.
Bye.